So we're talking about blepharoplasty and Browlift today, and uh, as I said, I'm a double board certified facial plastic surgeon. We'll see what that means in a second. But this is the reason we're here. Your eyes look tired, and you're not really feeling tired. So why is that happening? What are the age-related changes that are happening, and what can we do to help improve them? And so, little short bio, a little short bio about me, but highlights. I came from the Northeast to Austin 10 years ago. Before that, I was in practice as the founding director of facial plastic surgery at NYU Medical Center in the ear, nose, and throat department, the Department of Otolaryngology. Double board certified means I'm board certified in two things. One, my first board certification was otolaryngology, which is ear, nose, and throat surgery. And my second board certification was facial plastic and reconstructive surgery. And I've been active in the leadership of facial plastic surgery in the 30 years I've been in practice, 20 years in New York, 10 years here in Austin, and I have achieved pretty senior status in a number of organizations. But that just allows me to be super experienced in how other people do things around the country. I trained a bunch of fellows when I was in New York, so a lot of them are in very successful practices around the country. Many you may even recognize their names if you follow this kind of stuff. Anyway, so I got here to Austin 10 years ago, and I've been super happy here at Westlake. Some disclosures. I don't have any conflicts to disclose about any support that I've received from this presentation. I've had questions in the past whether all the before and afters that I'm going to show are my patients. They're all my patients, and I've done all their surgery and placed every little stitch that was placed during surgery myself. Um, and all included patients in this presentation have all agreed to be part of it. So what happens as we age? Well, here's an older looking woman, and she's, believe it or not, just in her mid 50s. So she's had a lot of age-related changes, sort of more rapidly than what we'd expect. We'll go through some of her specific changes in a second, but just in general, the age-related changes that we have in youth, we have the lower eyelid has a wall of support that is muscle, but then also a ligament that is the orbital retaining ligament, and it holds the fat back in youth. And as we get, and then in youth, the fat in the cheek is high and hasn't descended and hasn't deflated, and the bone of the cheek hasn't lost any contour. And as we get older, we have bulging forward of orbital fat because that orbital retaining ligament has gotten weaker. We have wrinkling of the skin and a little bit of sagging of the overlying muscle, but not very much sagging. And then we have an elongation of the length of the eyelid because of this bulging and because of what happens below the eyelid, where the fat in the cheek deflates and descends. And we also lose some bony mass that support the whole thing. So surgery for the lower eyelid at least should address many of these things. So in this particular patient, what has happened is we have this bulging downward of the orbital fat. It's limited to where it can go because the orbital retaining ligament is inserting in front of the bone here. And so we get a line of demarcation where that insertion happens, and below that, the malar fat has descended. So instead of being high as it was in youth, it's now lower. And then we may lose some cheek bone volume. So as a result, the eyelid itself looks much longer as we get older. A shorter looking eyelid is actually a beautiful sign of youth, and so it's something we try to recreate with surgery. The muscle weakens, fat bulges forward, and the eyelid looks longer and the skin wrinkles. Now, with the upper eyelid, we can have the itself becoming loose. Fat can bulge, just like fat can bulge in the lower eyelid, can bulge in the upper eyelid. Skin becomes loose, and the eyebrow contributes to the heaviness by descending. And then we can also get some ptosis, where the skin heaviness can weigh down the eyelid, or the levator aponeurosis, which is the ligament that helps hold the eyelid up, can lengthen as we get older. This is called ptosis. And if it's mechanical, meaning it's being weighed down, that's mechanical ptosis, and the treatment is just taking off the weight by either raising the eyebrow or removing eyelid skin that's causing the weight. But with acquired ptosis, meaning the eyelash line itself descends and gets closer to the pupil, that is a surgical correction that requires tightening that levator aponeurosis. So let's start with looking at a woman in her early 50s who has really maintained much of her good looks in her youth, from her youth, but she really is focused on what's going on with the upper eyelid. She doesn't like the heaviness of the upper eyelid. Her eyebrows may have come down a little bit, and when she smiles, she loses her eyes completely. And so, this is an example of a patient who would benefit from primarily an upper blepharoplasty, where the extra skin is removed. In this case, we decided to leave her eyebrows where they were. They appeared in good position for her age and weren't really contributing very much to that heaviness of the skin. And then we also did a deep peel. A header peel is a deep peel to address the fine lines and wrinkles that she has. And you can see the skin is much smoother after this deep header peel, and the eyelid is more luminous looking. And then, of course, some Botox can help unweight some of this lateral heaviness and make the eyes look a little bit fresher. And you can really see when she smiles now, her eyes don't disappear, and she just looks great. Um, Close-ups of the same patient after upper blepharoplasty, that deep header peel around the eyes, and Botox. The incisions heal universally very, very well. Hard to find a scar at all. Now, here's a younger woman, 37 years old, and she thinks that her eyes are making her look tired. So if we evaluate her, she has good eyebrow position, really no upper eyelid heaviness, and she has early fat herniation, so a little of that bulging of the orbital fat early that's tenting out that ligament that inserts. And then she has a midface deficiency, meaning this is more congenital, where the bone of the midface is not as supporting, and she's lost some fat. So worse on her left side, but her right side also has some of that stuff going on. You don't see it as much because it's being better hidden because the midface deficiency is less. So, but we if we just treated this side and not that side, it would look asymmetric. So we're going to talk about bilateral lower blepharoplasty. So let's talk about, first of all, how that's done. So lower blepharoplasty there's a bunch of different ways to do it. This is the primary way that I do it. We make a transconjunctival incision. This is a side view of the eyelid, the lower eyelid. Here's the eyeball. This is the lining of the eyeball. This is the upper eyelid. Here's the lower eyelid as it inserts. This is the cheekbone, and so um, this structure here is a hard ligament called the tarsus. Gives support to the lower eyelid. It's about 4 millimeters in length. And so the way that I get to help improve the fat that's bulging and improve what's going on below the bulge is the following. We go through, make an incision on the inside, just below the tarsus, and we go in front of the eyelid fat, where this black line I just added is, and we come down and release the attachment between of that orbital retaining ligament. We release it. Remember, that ligament is limiting what we can do to this fat. And so we want to release it so I can do certain things. Some what I prefer to do to help with this fat that's bulging forward is I'll remove some of the bulge and then I'll release into the upper cheek and move that malar fat. Remember, that's descended, that cheek fat. We'll move it up to help fill this gap. And the result is a shorter looking eyelid that's smoother. We use dissolvable stitches on the inside that last for about a week. Now, this is only a week after her lower transconj bleph, and I wanted to show her this case in particular because this is only a week. I mean, she very little bruising, very, acceptable amounts of swelling. Really hard to know that she had surgery just a week ago. I like that her eyelid is already looking less long, shorter. And remember, this is removing and then moving some of this cheek fat, this low cheek fat, up to give us volume and support in the lower eyelid. At a week before, sorry, this is a month now afterwards. Of course, she comes in with makeup. I don't ask patients to come in dressed in any particular way, but she's happy with how she looks. She came in with makeup, and in a month, she just looks fantastic. And smile is good. We do a medium chemical peel in her case around the eyes. I'm sorry, in her case, we did not peel her at all because her skin quality was good. Um, and close-ups, and you really see what happens to the eyelid. This is what I mean by shortening. When we do this operation, we get a net shortening of the length of the eyelid, which always looks more youthful by being able to achieve that result. Tensioning it, so looking up, you can see that she did have some bulging here on the right side, which was harder to see on the other pictures, and we improved all that pretty nicely and symmetrically. Great for men, inside incision. This is 6 months after surgery. His tired eyes look much less tired. He was a nurse who worked nights and always thought he looked tired, but it wasn't because of his night work. It was because his eyelid fat was bulging. Really nice improvement. Okay, so let's now, if we talk about those two things together, upper and lower blepharoplasty, and in this case, I had her peeled. So an older woman, wrinkled skin around the eyes, a lot of wrinkling. So you'd say, well, if it's all this wrinkling of skin, why don't you just take some of that skin out? And we do in severe cases, which I'll show you in a little bit. But there isn't skin excess. So if I ask her to look up, the skin is smooth. So if I remove skin and there isn't any extra skin, it would just pull the eyelid down when it healed, and that wouldn't be pretty. So a header peel, deep peel to smoothen things out is great. We'll redistribute the fat. We'll raise the cheek like we talked about, and we'll just take off the extra that's weighing down her upper eyelid. And she now looks more youthful, less tired, and just looks better. Close up showing the changes in skin quality and texture, tensioning the eyelids. There really is no extra skin here to remove. We just need to redistribute things and then tighten the skin with a peel. Looking up. All right, so another case of upper and lower blepharoplasty, but in this case, she does have extra skin. So this is a patient that when we look at her up close, tension the eye, there is extra skin, so he has to take it out. So in this case, I'll make an incision. Instead of the inside of the eyelid, it'll go on the outside, um, just so that I can take out the extra skin and at the same time support the lower eyelid. So this is removing fat, removing skin, and then removing just skin from the upper eyelid. Upper blepharoplasty is no, we don't remove anything other than skin these days. We used to remove muscle. We found that it created hollowing as patients get older. So now it's just a skin excision, take out the extra skin. Her eyebrow position's good, so she doesn't need a brow lift. And then the lower eyelid's just a lot more youthful looking, a lot less tired looking. So now we're going to start talking about brow lift. So this is upper and lower blepharoplasty with brow lift. And so um, preoperatively, we see heaviness of the upper eyelid, but her eyebrow position is lower than ideal for a woman. Ideal position of a brow in a woman is that it starts at the rim, at the bone, and then arches above it. And in her case, it sort of starts below the rim and stays at the rim. So the bony rim. So that's just a reference, an anatomic reference point, but it just looks heavy. And if I raise her eyebrows, it looks better than if they aren't raised. So we'll take out the extra skin, we'll raise the brows to unweight the brows, the eyelids further, and then we'll do a lower transconjunctival lower blepharoplasty like we've been talking about. So this is sort of a slide regarding what the Browlift technique is. Basically, we're making four incisions. Two are at the sort of at the level that of the height of the brow. These are small Z-shaped incisions, Z-shaped so that the hair pattern isn't disrupted and the hair doesn't separate along the incision. So it camouflages the much better if we create little Z's rather than straight lines. And then we do a lateral incision on each side. So these incisions are in order for me to be able to release the central forehead, and then these lateral incisions are for me to be able to release the lateral brow and down even onto the cheekbone. So the dissection actually goes all the way down over the bone. There's some nerves that we have to be careful about that we protect during the procedure. And then we go down laterally over the bone and all the way down to the where the zygomatic arch is. And that full release now allows me to move the brow without tension to a level that's required. So it's a deep release, a deep plane release or deep release that's right beneath the bony lining in the forehead. And in this area, it's in the deep plane. So, and then we fixate. We release, which is the main thing, raise and fixate the brow. Here we put little tunnels in the bone that I put a stitch in that helps to support the brow in its new position. And laterally, we just do stitches through the soft tissue. They work great. We don't need to use drains after this operation, and the results are very, very consistent. So here's 18 months after her endoscopic brow lift, upper and lower blepharoplasty, and we did a medium peel this time, Jesner's TCA 30% peel, because her skin quality wasn't very wrinkly. Improved when now the smile improvement, she also had Botox. So you see I added Botox there. Botox for the little wrinkly lines. But the inner wrinkles, she's still going to wrinkle here. We can't get rid of those completely with anything that we do, unfortunately. Um, Close-ups, just showing the nice unweighting of the upper eyelids, the smooth contour now, and then really nice appearance to the lower lid without that heaviness and shadowing. Again, the shortening of the lower eyelid, I cannot emphasize enough. This is something that I look at really carefully with my patients to make sure that we're getting that really beautiful, youthful shortening with this operation. Here's that first patient that we saw uh, about how we age, and so upper blepharoplasty, lower external blepharoplasty. So again, now this is from the outside because she actually does have extra skin, and then an endoscopic brow lift, really for unweighting. She has so much heaviness here that if I had just done an upper blepharoplasty, her brows would actually have pulled down a bit. And so this is to ensure that the brows stay where they are and unweight a little bit of that upper eyelid area. Smiley views, she looks a lot better, a lot less, a lot smoother. Incisions, really hard to find, right underneath the eyelash line, in the lower lids, and in the upper lids, impossible to find those incisions. Really beautiful result. And again, a, a natural a natural contour change between a soft bulge that's normal in the lower lid, and then a soft transition without a hard crease, a soft transition to the cheek fat that was raised. Sometimes the cheek fat is low enough or is causing enough deficiency that we need to do something extra. And so in this case, we might talk about doing a mid-face lift at the same time. And I do these mid-face lifts when I'm doing a blepharoplasty. I do them through the lower eyelid incision. So it's the same incision from the inside of the eyelid. We go down and we go down uh, and release the fat that's bulging forward, come down into the cheek now, and pretty far down. We have to come through some of these other retaining ligaments in the face. This is the orbital retaining ligament we've been talking about. This is a lower ligament that if we don't release it, the midface won't move. And so we release the retaining ligaments, all done from the inside of the eyelid. We'll smoothen back this fat and then lift the midface after it's released and secure it with some fine sutures to the rim, to the bony rim of the lower eyelid. So a patient with, I think, more significant midface volume deficiencies, and if I'd just done my standard surgery here, it would have been hollow in this area beneath her eyelids. So instead, we're do a mid-face release, and the release comes really all the way down to the end of the bone here, and allows enough mobility of the midface for me to bring it up under no tension. And now we have really nice smooth transitions between eyelid and cheek, and the midface volume is improved because it's been lifted. Some surgeons like to cheat, and I do this in the right patients too, but it's getting fat from somewhere else and using it to fill midface deficiencies. So instead of moving the midface up, the easier thing to do is to just inject some fat in here and give some volume where you want it. I really like to take patients' own tissues and move them if I can, because it's what makes sense to me. It's as we age, things descend and deflate. Well, we can inflate it if it's really deflated with fat, but in most patients, it's not a lot of deflating. It's mostly a descent of the tissues. And so by taking them and moving them back up to where they belong, then we don't need to camouflage that with other things like fat from other places. Close-ups of her eyes. Same kind of a problem with this patient, pretty significant midface deficiency, be below the eyelid fat bags. And by doing a transbleph midface lift, we can improve some of that. She had an anterior lower blepharoplasty because I thought she had some extra skin down low that I wanted to mobilize and bring up, and she got a nice result with that. Close-ups showing that more youthful appearance to her eyelids. Risks of blepharoplasty. So blindness. 125,000 patients reported to have blindness after this operation. The reason for blindness is usually uncontrolled bleeding into the back of the eye. And so, even though it's quite a rare complication, and let's see, not knock wood, I've never had this in my practice. We always caution patients that if you have increasing pain and decreasing vision in one eye, you want to wake me up and make sure that we get you in as an emergency. The intervention is to open the eye back up and control the bleeding. And I've actually had to do that in some car accident victims when I was in New York taking care of trauma patients. I don't do that here anymore, but I've saved some eyes doing that. Injury to extraocular muscles. There are muscles in the area of the surgery that help you move your eye. If it were injured, you'd have double vision that would require another surgery by another specialist to correct. I never had that complication in my practice. We actually take great pains to identify those muscles and protect them. Corneal injury is an injury to the eyeball, to the cornea. If you ever scratched your eyeball, you know what that feels like. It's awful. Um, it can happen with blepharoplasty if the eyelid gets a little dry underneath the protective lenses that we use. We always put in protective plastic lenses to make sure the eye is protected during the surgery so that corneal injury is less likely. But rarely we'll have a patient that has some dryness or something and a steroid drop must be used. Chemosis is quite normal. It's a swelling of the white part of the eye. We see a lot of it when we're doing either more extended blepharoplasties or combined with facelifts or other things that impair lymphatic drainage. So chemosis, something goes away by itself. We give a steroid drop to help it along. Lower eyelid malposition is the pulling down of the eyelid. We really, really try to take pains to make sure the eyelid is secure well. And the technique that I've just described to you with my lower eyelid blepharoplasties, where I raise the cheek fat, helps support the eyelid, so the risk of lower eyelid malposition is quite low. Many patients will have some transient malposition, meaning just from swelling, the eyelid will be a little bit lower, and then as the swelling goes down, they do a little massage and it comes back up. Lagophthalmos means we've taken out too much skin from the upper eyelid, so you can't close your eye, or we've done too good a brow lift and you can't close your eye. So it's quite a rare problem, but I have taken care of patients in my practice where the brow lift was too good, and we've had to reverse the brow lift some because it was causing an impairment of closing. So I've learned the hard way how to avoid that complication. And worsening dry eye, that's usually transient. It's something that will go away as the patients heal. Short, what's involved in the healing? Well, you get swelling that peaks in 2 or 3 days. Bruising some lasts between 7 and 14 days, depending on the patient. It's quite variable. The inflammatory phase of healing is from 2 to 3 weeks, and that's where the body recruits inflammatory cells into an area. Collagen and elastin are deposited. Contraction is when things sort of heal in, and that's where eyelids will tend to be a little pulley down. If they're contracting downwards, we can improve that with massage and other techniques to make sure they don't have a long-term problem. And then reorganization, we say it takes a year for surgery to heal, and that's because of this step of healing and reorganization, where collagen and elastin are reorganized and the wounds soften and settle completely. Things that I think, things that we do to help with the healing process. So, elastin regenerated nectar is a topical cream that helps elastin in the wound matrix, and it's very helpful in patients who we peel. We peel everyone after blepharoplasty, pretty much. So, elastin is an important part of the wound healing process. Retinol 4 weeks before at least 4 weeks of retinol pre-peel will help to reduce the red phase of healing from a peel, and vitamin C can help improve things as well. Little Lift goggles are great. These these are goggles that look like ski goggles, but they have foam on them. So they put pressure on the eyes. You wear them as much as you can for the first 4 days, and then at nighttime after that, because there's pressure being applied, you get less swelling, less bruising, and the healing time is much faster. So everyone gets these goggles as my gift during surgery. And the only problem is you can't see through them, so you have to take them off when you go to the bathroom or eat. But for the most part, if you leave them on, your healing is even faster. And then vitamin K is helpful for bruising. topical vitamin K, arnica pills. Mend shake. Mend is a nutrition shake that helps with wound healing that we always recommend. And lymphatic massage, super important to bring down the swelling by a professional lymphatic massage person, not just something you Google on YouTube, um, but is really helpful in terms of the healing process. So that ends my presentation. What's next? Well, first, please do check me out on Instagram at Dr. Constantinides. Um, Devin just logged back in. She's going to be following up with you by email, and you may schedule a complimentary consultation with Devin by replying to her email or scheduling online with her. You can also schedule a consultation with me by calling the Lamar Central office or by visiting our booking uh, uh, page online, westlakedermatology.com /book online. 10% off for all of you who have attended today. Uh, uh, if you'd like a formal quote for blepharoplasty and or Browlift, please respond to Devin's email. You must have your surgery by the end of April in order for us to honor that discount. I think it's a pretty good discount, and we look forward to seeing you soon. All right, so that ends my presentation. Devin, do we have any questions?
Yes, we had a few questions come through. I'll go ahead and start reading those. So the first question is there any timing to do the lower or upper blepharoplasty that is best? If done early onset of the fat sagging, could it recur? And if so, what is the timing?
Yeah, it's a great question. Um, so upper blepharoplasty first. So upper blepharoplasty, if you have extra skin in the upper eyelid and that extra skin is removed, then it is very unlikely for you to need another upper blepharoplasty in your lifetime. Um, the exception might be someone who's very young, but in many cases, those patients don't need an upper blepharoplasty. They sometimes would benefit more from a brow lift. Um, Lower blepharoplasty is different. Lower blepharoplasty, we're setting the fat back, the lower eyelid fat, we're taking some out and we're setting it back, and then we're moving the cheek fat up. So things look smooth. But then you'll age from there. So it takes about 15 to 20 years for the fat that's still that we don't take all the fat out. That would leave you hollow. So we just take out what's required. The fat that's there will bulge forward again. It takes about 15 or 20 years for that to be at a place where you might want to have another lower blepharoplasty. And those are done occasionally in my practice in patients who've had previous lower blepharoplasty.
Perfect. If you currently have mild dry eyes, would your chances of increased dry eye worsen?
Yeah, so like I think I said, dry eye will get worse with blepharoplasty. In everyone, even if you don't have dry eye, you will get dryness after surgery. And the reason is that the pump mechanism of your tears is lost because of swelling. So when we blink, tears are forced out of the lacrimal gland, which are upper part of the eyebrow, right underneath the eyebrow, and they're pumped across the eye and then collected in the little cannuliculi, little dots that are on your inner eyelid corners. And so if you lose that pump mechanism, you'll definitely have dry eye. Now, if you already have dry eye, you need to be real vigilant about using lots of ointments and drops during the period where your pump mechanism is impaired. But blepharoplasty will not or should not significantly increase your risk of further dry eye after the surgery.
Perfect. What are the risks of a brow lift and the recovery time associated?
Risk of brow lift. There are two sets of nerves that we worry about. There are nerves called the supraorbital nerves that run up from the upper eyebrow area up into the forehead. There's supratrochlear. There's another set inner, and then there's some other nerves. These nerves are the ones that allow you to feel your forehead and scalp. And so if I were going to cut one of those nerves during surgery, you would have a numb forehead and you'd hate me. Fortunately, that's not happened in my practice, but because we take pains to protect those nerves. The other set of nerves are the nerves that allow you to raise your eyebrows. They're the ones that you get Botox for. And those are the facial nerves, the temporal branches of the facial nerves that run up in from the side of the face up into the forehead. Those nerves really are not at risk with brow lift because we are quite deep to where they run, and so it's if the brow lift is done in the correct anatomic fashion, those nerves are really not at risk. Other other risks of brow lift. There's a potential risk for hematoma or collection of blood in any surgery that we do, but I've never had one in the brows, so not so I would say that that's a pretty minimal risk. Infection also very, very minimal. Um, Overcorrection we've talked about a little bit. That's we try to make sure that doesn't happen by planning correctly with the patient. Undercorrection is a possibility that we just can't get enough of a correction, enough of a lift, and patients, we might have to repeat the brow lift. That's quite rare. 1 or 2% of my practice uh, is a repeat a brow lift because it just didn't work the first time very well.
Do you ever do bone contouring during a brow lift?
I missed that. Sorry, Devin.
Do you ever do bone contouring during a brow lift?
Oh, great question. No. I know. So I use an endoscopic technique, which is minimal access, minimal incisions. To do bone contouring, we have to make a longer incision, raise a flap. I so I'll work on the bones of the forehead if there's a growth like an osteoma to remove that or other types of things. But for cosmetic sort of frontal bossing and try to improve the shape of the forehead, no, I don't prefer to do that. There are other very good surgeons in town that will do that for you.
What type of anesthesia do you need for surgery?
Um, the most common type of anesthesia is with IV sedation by me. So we'll put an IV in, give you some medication to make you, it's like a colonoscopy-like experience, and you basically drift off to sleep and don't have any recall of anything unpleasant. General anesthesia is an option, but usually that's not required for this. Most patients would just do it under IV sedation.
Is this an outpatient surgery?
Yes.
Perfect. Next question. Does weight loss or potential weight loss impact the decision on when to schedule this type of procedure?
It really has to do mostly with what's going on in the midface and eyelid area, so the lowers and the upper face. If you're first of all, I have a strict cutoff where if you have a BMI, excuse me, if you have a BMI above 32, we will not do your surgery. I'd rather you lose some weight, and that's not because of the surgery can't be done. It's because there are other medical problems that could occur, complications that could occur if you're very heavy. So 32 or lower, BMI is fine, and it just might impact um, how much uh, where it'll really depend on where your anatomy is and where your fat is. And can I effectively improve the whole area with the fat that you have? So that's an answer to be reserved when I meet with you.
All right. Would insurance cover any or all of this procedure?
Oh yeah, that's a great. I should have mentioned that. I'm so sorry. So anything related to upper eyelid vision is covered by insurance. So if you can't see because your eyelids are droopy enough, then insurance will actually cover your surgery. You need to get a visual field test, which is a test that documents what your visual loss is, and that you can do at any optometrist or ophthalmologist's office. Bring that result with you, and we can educate you as to whether insurance will cover it or not.
Perfect. How long do you have to limit activity and exercise after a blepharoplasty?
So you'll have swelling. Even if you use lid lift goggles, you'll have pretty significant swelling. The more you do too early, the more swelling you'll have. So we recommend really you take a week off, no exercise. You can, take short walks in the latter part of the week. For the first 4 days, you're going to be using lid lift goggles. After a week, it depends on how much swelling you have. That patient that I showed you, that younger patient with hardly anything at a week, I mean, she could start back in but with everyone, once you start, you just pay attention to what's happening. And if you're getting a lot of throbbing and swelling, then maybe you're doing too much. So just use common sense. And that's basically the advice I give everyone.
Perfect. Is a patient with a diagnosis of Sjogren's still a candidate for a upper blepharoplasty?
Upper blepharoplasty is not a problem with Sjogren's. It's the dry eye doesn't get worse with upper blepharoplasty.
Perfect. Um, would I be able to return to work after 1 week following an upper and lower blepharoplasty?
Most people go back to work after a week. But if you're actually working in an office with face forward interactions with clients and that sort of thing, you may want to wait an extra week for that because even though you'll be able to go in and start to work, it'll be, you may not feel comfortable with how much swelling you still have at a week. So most patients go back to work at a week, maybe in a limited capacity or work from home. Remember, your eyes are going to be tired more easily after the surgery. So, and you'll have some blurred vision for the first week or so. So don't expect to do like a 10-hour workday the first day back. Ramp yourself gradually back up into your full workload. Give yourself an extra week to get back up to full workload. You can fly after 2 weeks, and most people are starting to do more aerobic exercise and that sort of thing at 2 weeks.
Great. Can a brow lift improve the cheek muscle to some degree?
Um, I think the answer is no, but I guess I'd need to know more about what you're asking about with that. Sorry.
All right. What is the best age for a blepharoplasty? Is 71 too old?
The best age is when you start seeing things you don't like. And so I've done, lower blepharoplasty. My youngest is 20-year-old girl who had congenital bags, and it was congenital. So it's whatever the anatomy dictates is the best age to do it. I mean, whatever, if your anatomy is telling us that you'd have a good result, then you have the surgery. 71 is by no means too old for anything. We do routinely do blepharoplasty, brow lift, facelift in patients well into their late 70s and early 80s.
All right. Where is the surgery done? Is it in office or at a surgery center?
The surgery is done at our Joint Commission accredited operating room, which is in my office at Westlake Dermatology at Lamar Central.
Perfect. Sorry, this one's a bit long. Let me just read it. Okay, so it was a question about one of the before and after photos that you showed. The patient or the questions is asking about the eye size discrepancy, dramatically magnified. What causes this? If I already have one eye that appears bigger than the other, would a upper bleph exacerbate that?
Yeah, I'm not exactly sure which patient you're referring to, but I'll just answer in general. So everyone has asymmetry in eyelid shape. Go ahead,
It
Debbie.
was the male patient, the one that you said was a nurse that worked
Oh, I
overnight.
see.
Yeah.
I don't remember a big eye discrepancy on that patient, but nonetheless, I'll just answer the question in general. In general, the eyes look different in everyone because of orbital volume differences. So the bone size and support for the eyelid is different one side to the other in almost everyone. And so with surgery, we improve each eye so that it looks good in terms of what the anatomy looks like. But any asymmetry due to underlying bony anatomy will still be there. And so maybe that's what you're seeing in that patient.
All right. You might have answered this one, but did you touch on the recovery time for the brow lift?
I don't recall. So there's stitches for a week. You're swollen. If we're just doing brow lift with nothing else, you're swollen. Your swelling will settle down around the eye, so you still get lid lift goggles to wear because it keeps the swelling out from that area. Um, and black and blue again will track to the upper eyelids and sometimes even around to the lower eyelids and then go away from there. And it's the same kind of time frame for healing as blepharoplasty. A week, you really don't want to be doing very much. This go back to work in a week, and then most patients are doing sort of a full workload by the second week. Um, and I cannot stress enough that lymphatic massage is so important to get people back into their lives faster. And so we give recommendations to of practices that we like who do lymphatic massage well, and we cover that at your consultation.
Perfect. That's the end of my question list, unless somebody, oh, actually, I just had one more come through. If you have a large forehead, would that interfere with a brow lift?
That's a really good question, and I forgot to mention this in one of the patients I showed, but there's a patient that I showed with a fairly high forehead, and so I did an endoscopic we did an endoscopic brow lift, and if you look online and ask Dr. Google, you'll see that the answer is if your forehead is too high, endoscopic brow lift will make it higher because we're lifting up, right? So it'll move the whole hairline back. Actually, it doesn't do that. And the reason it doesn't do that is that the release goes also backwards a bit. And so it's really a contraction in two directions that create the brow lift effect. And so the hairline height has very little to do with outcome from brow lift. Endoscopic brow lift, it patients even with high hairlines, that doesn't change enough for it to be an aesthetic problem.
All right. Well, that was the end of my question list, unless anyone else has a last minute question they'd like to type in our question box.
Well, it's just wonderful. Thank you so much, everyone. It's been 50 minutes. What a great session. And I really, really appreciate everyone hanging in there who has hung in there this long and to see us talk about this really fun and fun topic. Thank you very much. I look forward to seeing you all soon.